Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm one of your hosts, Brian Waterman, a sports and shoulder elbow surgeon at Wake Forest. Also joining us is my esteemed co-host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. Peter, how are you doing today?
I'm doing great. I'm really excited to do this with you. Thanks for leading us off.
Absolutely. That enthusiasm is definitely shared. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect that of the ASES, University of Utah, Wake Forest University, or any of the institutions of our guests. And with that out of the way, I want to usher in a very special podcast that we have arranged for our listeners today. We're honored to have two incredibly knowledgeable and talented guests tonight, both of which are giants in the field of physical therapy and shoulder elbow care. First off, let us welcome Dr. Lori Michener, who hails from the University of Southern California, where she is professor in physical therapy. Dr. Michener, welcome to the podcast.
Thanks. Excited to be here and talk all things shoulder.
Fight on, Lori. Fight on. Next, we have and are pleased to have another leader in the field, Dr. Lynn Snyder-Mackler, the alumni distinguished professor at the University of Delaware, where she has worked for the past impressively 36 years. Quite the feat. Dr. Snyder-Mackler, welcome to the podcast.
Yeah, thanks. Glad to be here. Looking forward to this conversation.
Well, to say the least, both of you definitely embody the importance of being inquisitive and kind of seeking ways that we can better address the needs of our patients, really in a very holistic way. Your professional background started in physical therapy and athlete care, but your involvement has extended so much further, and it's definitely even evolved over time. So maybe for those listeners that aren't as familiar with your work, could we start with your education pathway and what are your current roles and responsibilities at your respective institutions? Maybe Dr. Michener, if we could start with you first.
Sure. I started out in athletic training and trained in Pennsylvania at a small school, Lock Haven University, and then went on to physical therapy school in Buffalo, New York. Then worked for 6 years in collegiate athletics with a hiatus for 1 year and outpatient PT. And then really thought I wanted to understand more questions that I had that didn't have clear answers, so went back to get my PhD at Waterman University in Philadelphia, and then started working in physical therapy education at Virginia Commonwealth University, where I really started, really my research career in understanding mechanisms of shoulder pain and a lot of focus on rotator cuff disease and understanding then also treatments that may be helpful and outcomes that we may consider in trying to understand if our patients are getting better or not. And then about 9 years ago, my husband took me kicking and screaming to California because he had a fellowship at the other school across town, UCLA. We got to say that often in my house, of USC. And I've enjoyed a fantastic 9 years here and really has accelerated my research questions and collaborations across the division to answer even bigger questions that I was doing prior. So I've moved in from athlete care to care across the spectrum of age groups, and today we'll talk about OA. Of course, I've done a little bit of work with that. Thanks.
Yeah, Dr. Snyder-Mackler, let's talk to you. How about tell us how you arrived where you are today?
Oh, you got an hour?
We have as much time as you need.
I was an undergraduate at Johns Hopkins, where I played sports and went to school, of course. And then I did a postgraduate certificate program in PT at Penn. I also, while I was an undergraduate, went through not an athletic training program, but back then you could go through an apprenticeship to do it, which went away probably 10 years after that. So I also have, as my training certification, physical therapy. And I worked for just a couple of years in outpatient orthopedics, and then started as a professor at Temple University in Philadelphia. So it was 1983, and I was at Temple for a few years, and then we moved to Boston. I took a job at BU and enrolled in a PhD program. So I did a doctorate in applied anatomy and physiology, and again, this is like a couples thing, right? Same as my late husband was doing his residency in Boston which was why we moved up there. So, and then we were, looking for jobs concurrently. He had been trained exclusively at Penn except for his residency years, and was offered a job there. And I took a job at the University of Delaware. I've been there ever since the fall of 1989. I am retired. I'm an emeritus professor right now. I have been for a couple of years, still doing research at Delaware and elsewhere with other collaborators. And my research focus has really been on why the quad doesn't work after knee surgery. So it's really, really been my focus. But I've always practiced, and shoulder and knee were my two areas that I took care of. And then I also did research with my current husband, in youth baseball. So looking at prevention of shoulder and elbow injuries in young baseball players.
Certainly that background is so interesting. I think much of the work that you've done with the quad and the ACL is also going to apply to us in the shoulder, certainly when we think about rehabbing patients who have shoulder dislocation, but also patients who have cuff repairs. Maybe what have been some of the things you've learned about getting muscles to reactivate after that kind of major ligament surgery that you feel like also apply in the shoulder? Give us some of the highlights.
Okay, I think that my other big research area was neuromuscular electrical stimulation, and I think it has a huge role to play in shoulder rehab, as well as in knee rehab, because certainly part of the rotator cuff dysfunction that happens is, well, not just rotator cuff, but like after an arthroplasty, you have like sometimes the deltoid shuts down, right? It's just, that's an activation failure. There's nothing wrong with it. You just have to remind the brain how to activate it. So I think STEM is the biggest carryover for neuromuscular electrical stimulation, is the biggest carryover from what the work I did with the quads to what we do in the shoulder. It's kind of a...
Really, that's it. No, I love that. That's very actionable, and I think is great advice. Laura, you've also done a lot of work here in biomechanics and in outcomes. What, a lot of this has been multifaceted. I wanted to ask you specifically about outcomes. You've worked in a lot of fields. What are the things that maybe we should be collecting that we're missing? What about fear of re-injury, grit, resilience, kinesiophobia? What are the kind of takeaways you might have for us there?
Every time you do a randomized clinical trial or an observational longitudinal cohort or even a simple case report, the publisher, the reviewers say, what's your primary outcome? And it's always, can you name just one? And I still have an active clinical practice, and I find that very challenging when I think about my individual patient in front of me. And I also now find it challenging in these clinical trials to narrow it down to one, because one outcome measure likely doesn't capture the complexity for the patient. So you kind of touched upon, are there psychological factors that are interfering potentially with their recovery? But even from an outcome measure perspective, asking the patient to fill out a legacy measure, such as the ASES shoulder score, tells you about 10 activities that they commonly may do. But what if there's specific activities that they really want to do? In other words, what's the important things to them? That outcome measure, and nor does any legacy measure, ask them to also identify if these activities are important to them. So I think about the patient-specific functional scale. Tell me 3 things that you want to do that you can't do because of the problem you're here for today. So it really, I think, helps to focus on the patient. And then the last piece I'll add is asking the patient a simple question, which I've started using in my clinical practice as well. The path, if left the way you are today, given your symptoms and your function, would you be satisfied 6 months from now? That patient acceptable symptom state. It really helps you understand contextually if 20% disability that they still have, is that good enough for them? Does that make them happy and go, I don't need to do anything else or keep coming to therapy or seek medical care, for example?
A really good point. I know you asked about some of these, like fear avoidance or those kinds of scales. I want to put that as a primary outcome measure, because in general, the people who have the highest scores on those instruments are those whose recovery hasn't been good. So it's because is your answer, are your answers to this question because of your knee, the condition of your knee, and that then you see the answer is often yes, or the condition of your shoulder. So they're not strong. They didn't get full motion back. They have residual pain, right? Those are all reasons why they would have less confidence. So they kind of go hand in hand, those different constructs that we measure as we have somebody going to rehab after an injury or surgery.
Yeah, Lynn, I love what you said about the quad shutdown and really this broader concept of arthrogenic muscle inhibition, which I don't think has quite made its way up, at least from a community standpoint, to the upper extremity. And then also looking at these more actionable things rather than MCID. Lori, I love both of these concepts because I think it really has led to a paradigm shift in the way we approach our patients.
Yeah, I can't agree more. In the MCID can be helpful that people are getting better, but are they best? Are they where they want to be? And the MCID can't capture that, and it's so helpful to just be able to understand what the disability is with them.
It's a psychometric measure, and it can have a really wide variance. When you talk about it it's not the instrument, it's the instrument in the care of something, right? Rotator cuff tear, shoulder instability. Those MCIDs are going to be different for all those populations, right? So I find those helpful for interpreting the literature, but not particularly in a patient context. I don't find them helpful at all. Because those MCIDs are not, that is not for individuals. It is for group level data, right? When you look at the change from one step in the process to the next to see if it exceeds the MCID is for, as I said, group level data. It is not a number that you can use or should use. It's not designed for that in clinical practice on a single patient.
Yeah, excellent points for those individuals that are trying to interpret the data and also, trying to see how we can utilize that in our practice is good. I must confess, Peter and I have a little bit of ulterior motives, and I wanted to segue, if we could, to a discussion more broadly about shoulder arthritis.
So what's your motivation?
I'll give it to you. There definitely seems to be a disconnect between the recommendations of our professional communities, our anecdotal experience, and really the mandates of the private insurance carriers. And really, it's about this concept of the use of physical therapy preoperatively, postoperatively, and what our goals are. And I really want to dig into the guidelines, the clinical practice guidelines that were laid out in 2020. And this was both a combination effort of the ASES and ASET, the American Society of Shoulder Elbow Therapists, which is a prominent group in your field. You know, what it suggested is there was no evidence to support the value of preoperative physical therapy, or maybe it was just only applied to certain individuals. So I was wondering if we could launch in on that. Certain insurance companies require, like Aetna, for instance, requires you to have 6 to 12 weeks of formal physical therapy before they'll approve a shoulder arthroplasty. Mm-hmm. So, Lynn, can you help us settle this debate? Who are the right patients for this? What do you think?
I mean, I have my own experience of having had a total shoulder 2.5 years ago. We always do prehab with our, but it's very goal directed. We're trying to get them to the limits of their bony motion, right? The bony limitations that they have, if they have with significant arthritis, and get them as strong as we can get them preoperatively. Those are the goals, and sometimes it takes only a couple of weeks, and I think we've been successful in just making that point to Aetna, for example, that we've reached the limit of what we can do. They're still not happy, right? They still need the surgery, and they're ready now. So that's pretty much how we do it. We found them. It's crazy as it is. If you're not getting some AI going over your submission, saying no without any real intellectual input, I think it usually works. So I'm not a real big fan of it. You have to do 6 to 12 weeks. I mean, you have to get them back as much motion as they possibly can get back before surgery, and then strengthening. And I did probably 6 weeks of pretty intensive PT before my shoulder arthroplasty, and the therapist did a great job getting me ready.
I could follow up with you. I think that makes sense before surgery, but I guess the bigger question is, let's think about your experience. I want you to think about before you decided to do the replacement. Mm-hmm. So in the setting of non-operative treatment, there's no replacement plan for the near horizon. Is there a role for physical therapy for that patient?
Oh, sure. That's our bread and butter, right? People who are arthritic shoulders, they have pain, they have loss of range of motion, particularly if their loss of motion is really impairs their function, right? So they don't have a functional range. You can almost always get that back, right? It requires work on the part of the patient, and it requires imagination sometimes on the part of the therapist, because they're big, despite the fact that the motion is bothering them, restricting them from things, and their strength may also be. They almost always have pain. That's a significant contributor. So again, as PTs, we can deal with all of that. And so, yeah, I mean, that's, again, we're the ones who are treating them except if you're doing like injections or something. You're not really treating them per se. We are, for those impairments. Lori, what do you think?
I think that strengthening, restoring range of motion as best as possible is an appropriate goal preoperatively. I agree it's not the same for everyone. I don't think it has to be 6 to 12 weeks or whatever Aetna or insurance company decides. It may be very difficult for a patient to exercise in the presence of significant OA pain. And sure, some type of other approach rather than just strengthening may be really helpful to reduce their pain, but it still may not negate that enough to say, all right, I'm going to be quote unquote strong enough and mobile enough before surgery. So I think it's a individual patient, and I would rather see Aetna go towards, you have to try a bout of PT and not dictating how many weeks, because I think that varies per patient. And patients vary showing up as well.
Yeah, that's true. And taking it's not passive. This therapy is not passive. They have to be active participants to work, and so that also is, as you said, difficult in the face of pain. And although there are things we can do to try and ameliorate that pain, so sometimes movement in and of itself is good for pain relief. So
maybe I could follow up on that specifically. I can totally understand how, if you have limited range of motion, physical therapy is extremely effective for restoration of range of motion. I think that's probably the very heart of physical therapy, one of the very core tenets of physical therapy of the shoulder. Talk to us a little bit about pain relief, because that part I think some surgeons will struggle with. Tell us the manner in which you think that physical therapy relieves pain for arthritis, because I can believe it does. I just want to understand, like, where you guys have done so much research. Lori, where do you think it actually works for that? Like, how does it relieve arthritis pain therapy?
So simply sensory input into the system can help readjust what people are interpreting pain in their brain. I am not saying, let me just be crystal clear here, I am not saying OA pain is in the brain only, but people may have a higher level of pain experience, my phrase that I like to use, and they may be interpreting this pain that's coming peripherally, but it's really getting exacerbated in the brain. And it can help giving some input, even from active exercise. We've shown this as well to help reduce this pain experience, if you will, but also just from the sensory stimulation just directly might be helpful in resetting these peripheral nociceptors as well. And do I think that in some people with low-level OA, maybe this is helpful to even really reduce their symptoms enough that they don't want surgery? Maybe, but I'm thinking by the time they're scheduling for or contemplating a total joint replacement, that likely it's helping to reduce their pain, not ameliorate it completely. So mechanistically, to get back to your question, likely the sensory input that you can provide, either manual therapy, exercise approach in a non or reduced painful range, can be quite helpful. I'll harken that back to like some things like patellofemoral pain, and we're going to do some isometric contraction, and that's been shown to reduce patellofemoral pain, for example. So just activation of things around the joints as well as passively doing some things can be quite helpful.
Low-level joint mobilization, low-grade joint mobilization activates the fast sensory fibers just like stimulation does. So it can kind of gate control, beat the pain to the brain, for want of a better explanation.
Yeah, Lynn, I was wondering if I could lean on your experience as a patient. You know, what were the actionable goals that you were able to obtain? And I'm curious, do you equally feel that modalities and manual therapy are effective in this population?
Oh, for sure. For sure, exercise, different kinds of mobilization, electrical stim, and all those things were very effective. Also, just resisted exercise, stuff like that. Stretching, I mean, they were all effective, both for a very long time in keeping the surgery at bay. right? So, I mean, I had pretty significant arthritis for about a decade, but was able to keep things at bay with rehab and an occasional injection. But you have to be diligent about it, right? I mean, you have to participate. As I said, but in terms of modalities, we're not using passive modalities, like just weigh something down there. But we'll use electrical stimulation of muscle. We'll use electrical stimulation for pain control. We'll use biofeedback, EMG biofeedback, again, for getting the muscles active. I'm always concerned about that. I mean, I think, as you said, it is underappreciated in the shoulder, but it is clearly a big problem post-operatively. This shutdown of, a big muscle like the deltoid, it doesn't make any sense why it won't fire, but it's not firing. So you have to sort of figure that out and get it firing again, right? That is, as I said, very similar to the quad after a knee injury or knee surgery.
Yeah, Lori, anything to add on that? I think a lot of times, Peter and I see these patients in the office, and let me paint a picture for you. It's, the patient that's somewhat catastrophizing. Maybe they've got a little bit of a bony conflict with, B2 or biconcave glenoid. And so, oftentimes I struggle to get their buy-in on this concept. And I think sometimes there's a little bit of a disparity in who which therapist that patient sees. So I'm curious your thoughts and goals on this patient and what else you've found to be more effective.
So let me clarify, the buy-in for the patient to go to physical therapy?
Yeah, to a certain extent. And then specifically that individual that has a little bit more of an advanced wear pattern where I do feel that there's an impediment to range of motion. It's not somebody that has a concentrically reduced shoulder at this point, but they've had a more advanced erosive wear pattern.
Yeah, I think back to the individual patient conversation and I didn't mention before, imaging. Okay, how much can we restore? And the conversation with PT saying, here's the advanced wear pattern. Here's some things where we are not likely, going to be able to improve motion above 100 degrees, secondary to what we see in the imaging. And so I think that's an individual conversation to have and realize enough wear or enough bony changes really lend itself to limited ability preoperatively to achieve that. I can't, on the patient limited buy-in, that's an important part, right? If they are just, no matter the conversation you have, they just feel like, all right, I'm going to try a little bit of this, but I can't imagine this is going to be helpful. I think we need to rethink the patient education piece with them and delivering that. But if that really isn't successful, how much more do we ask the patient to do, the therapist to do, that is not going to bring any positive benefit or limited positive benefit because of that? Did that enlighten that answer or that question that you had? Did I answer that? You'd say?
Absolutely.
Yeah, I think that's that's
go ahead, Peter.
Great. Well, I was just saying, I think that this really gets to the heart of this talk. Because for me, I mean, the challenge we have so often on our side, speaking for Brian and I, is that the patient comes to our office and the question is this a patient who potentially could benefit from physical therapy if they have osteoarthritis? And I think what we're all agreeing on is if that person has incongruity of the joint, if they have, a flattened humeral head, for instance, and now they have a flat on flat instead of a round on a ball and socket, and that patient's, no matter how much stretching we do, probably not going to get much improvement in their external rotation. One of the things I wanted to ask you guys about is patients all the time in clinic will say to me, patients with arthritis, they'll say, if I don't do much activity, my shoulder doesn't hurt that much. My shoulder hurts a lot more when I move it. And so I'll see people with poor range of motion, and it's almost a learned disability where they've said, well, I stopped moving it because it hurts so much, and now I really can't move it. So I guess my question is, that seems to me to be such a solid impediment to success with therapy. So how do you get around that? How do you get around the pain that is activity related? What strategies do you use? Does that mean that we should be sending the patients for injections first and then to do therapy? Should we be doing more with timed anti-inflammatories? Are there things you're doing on the modality side so that we can improve range of motion and strength without kind of stirring up that activity-related pain? I want to hear from you, Lori, but then Lynn, you've lived this. I want to hear your lived experience with this particular aspect of it.
I think that there's an opportunity to talk to them about how to do some activities that could improve the muscle function in a lower ranges of motion that are not symptomatic. But that, again, is how well can the patient do that that's sitting in front of you? And so giving them, here's why we're trying to work on some exercise beforehand, if you're going to end up as a pre-rehab, if you will. 2, injection, excellent. Doing some activities that can help stimulate that nociceptive reduction might also be helpful. But asking the question, how long do you persist in that before surgery, really is the best option.
I agree with you.
Lynn?
Yeah, I agree with you. As I said, my experience was before I really wasn't having horrible pain. It was sort of as bearable as it had been for the last decade, but I had my posterior glenoid was eroding to the point that I was going to need the biggest offset of the glenoid component, and if I eroded any more, I would need to have a reverse PSA, which I did not want. So going into it, I really didn't. It wasn't like this horrible pain that woke me up. Every once in a while, it would wake me up at night, but it wasn't something that was. I wasn't like popping NSAIDs all the time. Post-op, it was. It was really painful, but moving it felt better. When like I could just let my arm hang and just move it a little, just swing it a little bit, it felt so much better than being in that abduction immobilizer. So motion helped, didn't hurt. Of course, I had to be careful of the structures that were sutured back. So subscap, for example, just being very careful while those stitches healed. But motion really helped. That's the best I can say. I mean,
yeah, motion is the lotion. You all have taught us so much about this, and I think you're constantly navigating us through our fear zone of failure of subscap, because that's a difficult problem, the likes of which is really difficult to solve.
You've got to know that the physical therapist has a very good handle on the osteo and arthrokinematics of these joints that we're training, right? So we know what will stress that anterior capsule, what will stress your repair of however you exposed the joint with the subscap and the capsule. Like we know what the motions we shouldn't be doing early on in this process. But that doesn't mean no motion, right? There are many safe motions after a total shoulder, for example, that people can do. And you could do active assistive, you could do active. There's lots of ways to get at motion, right? Mm-hmm. But I think that what happens is you're right. You're afraid of failure. So you just say, I don't know who these therapists are. You're not going to do therapy for whatever. Don't do therapy for a couple of weeks, or don't do therapy for a month. I think that's a really bad idea in the face of a arthroplasty.
Yeah, Lynn, I was wondering if we could pivot then to the rotator cuff deficient shoulder. Again, framing it out as the goals of our preoperative discussion. Very often we have the cuff deficient patient. We don't know what bucket they fall in. We don't know if they have true pseudoparesis. Is this a pain mediated presentation? And so I'm curious if we could establish some common goals on what we want to accomplish. And then secondarily, I'm really curious if is there a modern day application of this deltoid reeducation pathway that we often hear discussed about in the cuff deficient shoulder? Maybe we could start with you, Lynn.
You could probably start with Lori.
Yeah, sure.
In the cuff deficient patient, right? You are depending on the prime movers, right, for the motions around the shoulder. And there are people who are remarkable with the adaptations that they've made and their ability to elevate the arm. Lori's seen these folks too. You're like, wait a minute, your cuff muscles are all shot, and here you are lifting your arm above your head and doing all these things. We've been monumentally unsuccessful in training patients who don't automatically adapt like that to be able to do it. So I always thought we could, but we haven't been very successful at it. But some people are able to really use the prime movers to get their arm where they need it to be. But I mean, just the range of people who have cuff arthropathies and how they present it's every single one is a different story, right? You got to figure out what they can do, what they can't do, and how you might be able to help them, or if it is like, go get a reverse total shoulder and you'll be able to move, right? And you won't hurt it. Lori?
Yeah, think about the cuff deficient person who's using the primary movers, as you suggest, and deltoid, and especially in those patients who are having a hard time even activating the deltoid enough for function. That's kind of, Brian, who you're talking about, or was it Peter who brought this up?
Yeah, maybe it's two questions bundled into one. The first is the goal for the cuff deficient shoulder as we're considering this evaluation of a patient for reverse shoulder arthroplasty among the plethora of non-operative options. What would be the goals that you would set out for that patient?
Yes, they're cuff deficient, but is there ability to retrain any part of that cuff that remains that can help with improving that stability and then thus being able to get the coordinated force couple somewhat back? I mean, or is it really training more the primary movers, as Lynn has mentioned, in that seeing what we can recover before they may end up having to have surgery, I think is a role. I think this is also a role for potentially eStim in this population, because I see people who are cuff deficient, but it's not that they don't have any ability to activate that cuff. And so how do we work on activating that in a gravity eliminated position first, and really trying to activate what they have remaining, and then working on supporting the cuff deficient while we're improving that ability for the primary movers to elevate, externally rotate, etc., the arm outside of the cuff. Is that?
Well, I think that's really, yeah, that's really valuable. I want to give each of you an opportunity. I mean, this is like a rare opportunity you have to speak to like all of the shoulder and elbow surgeons out there. what else do you kind of wish you could share with surgeons? Like, what are the things when you see patients referred in, or in the experiences the extensive experience both of you have had? When you look back, what are things you said, God, if I could have told all shoulder surgeons this en masse, this is what I would have told them? Maybe starting with you, what are maybe some lessons that all of us could learn?
You said Lynn or Lori? I missed the last section.
Lynn.
You might as well start.
Oh, okay. When a patient comes out of surgery, very helpful. I'm in a medical center. Let me start first. I'm in a major medical center. I communicate well with our physicians, who are primarily, they're the people I'm seeing patients from. But if you're in an outside hospital system, outside the major medical center, and you're seeing patients, I need to have the OR report, and I need you to have a barometer. Give me a barometer of, are you concerned? Are you have at it? Very limited precautions. But not getting an OR report, or even getting an OR report without a barometer of aggressiveness and any precautions, quite simply, is challenging. And I think outside of shoulder, people who specialize in this always ask these questions of the surgeons that they may not get that from, but not everybody asks that question, and that can lead you down a very bad path of rehab if you don't have those pieces of information. I also think another thing is, don't be afraid to ask the therapist to evaluate the patient and give you a consult back. I think sometimes people, like I grew up in the athletic training, collegiate athletics, and that's how I've always operated. That's the only way I know to operate, is having a consult feeling and conversation with the physician. I'm seeing the patient. I'm like, hey, listen, I want to tell you, I think they have a full thickness rotator cuff tear here. I don't think they just have tendinopathy, for example, and I think you need to consider getting X, Y, and Z. Oh, great, thank you. I don't know that is an easy dialogue, and sometimes maybe it's not, because it's not invited in the surgeon world. I'm not sure that all the responsibility lies on that end. I think it lies with therapy as well, to say, listen, here's my opinion about this. And then saying, tell me whether or not they're appropriate for physical therapy, and understanding that they don't need to keep going. They may be a simple 1 or 2 visits of the consults. That's the ones I can think about for right now that I always come to the top of my mind with shoulder surgery. Lynn?
I agree with you. I think op report is pretty critical, and a sense, I would say, of I assume that everything went well if that's all I get, right? Everything went well, normal course. But let's say it wasn't normal course. It was a rough go in the OR. Maybe there's more friable tissue than you've seen in other places, and you have a real reason to put the brakes on for a while to allow that to heal. That's a really good thing to know.
Mm-hmm.
Peter and I certainly see the value of a collaborative relationship, and I would just like to echo what you've said. We're at a location where we're able to do kind of communal rounds on early post-ops and have a back and forth in person. Not everybody has that luxury, but I think we as surgeons think we're better communicators than we are. And what I'm hearing from both of you is really open those channels for optimized care.
Yeah.
Not only that, but I think it's interesting you guys would want the actual operative report. I think many surgeons would assume you would just want the PT protocol, but I'd love to hear that you would like to get farther into the weeds to read the actual operative report. I mean, that's, I think, really valuable for surgeons to hear.
It's really important, and to be honest, I would prefer not to get a protocol from you.
Lynn and I might disagree on this. I like a protocol to understand the approach that that individual physician, likes to follow. And then can we have a dialogue about that? Listen, I want to really do, my approach for rotator cuff repair is I like to do delayed motion. Well, with this patient, just looking in the OR report, and you've said, in the meter of aggressiveness, you can be pretty aggressive with this patient. I feel like they had good tissue, had a good repair. Go ahead and have at it. Then it makes me have an easier dialogue then if there is a protocol to then say, hey, listen, have you thought about maybe even shortening that delayed a little bit, because it seems like they had pretty good OR tissue stabilization, repair, etc. So I like the OR report, but I really also like the aggressiveness meter. Like, should I be careful? Do they have poor tissue? Like, what's happening?
Well, certainly those insights are going to be valuable for our listeners. I want to thank both of you for coming on. This has really been a tour de force, and it will be incredibly valuable to hear, the reasons why physical therapy can work, the situations in which it works. And then, Lynn, I want to thank you for, sharing your lived experience here, the process of actually going through it as someone with as much knowledge as you have about physical therapy, and then the personal experience of this is what worked for me, this is when it really worked. That's incredibly valuable for listeners. This is about all the time we have for this episode. Again, I want to thank both of you for taking time from your ever busy schedules to pay for our listeners. And I can assure you, we're always going to be able through collaboration with our interdisciplinary teams and our patients who reap the benefits. So from the bottom of our hearts, thank you so much for coming and the contributions you've made to the field of musculoskeletal care. All of our shoulder and elbow listeners out there, yes, please. Fine.
No, I just said thanks for the invitation.
Of course. Thanks for coming on. For all of our listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we will see you next time.